help the presenter to present in a very clean way because the sessions are being recorded. So when you put it in YouTube or Facebook, the recorded video, there won't be any disturbance so that this information can be accessed without much of disturbance. So once again, I would like to welcome all the participants who have been consistently being part with us. And thank you very much for showing your interest in academics. So on behalf of NNF Karnataka State Chapter, our office president, joint secretaries and executive board members, we would like to welcome today's speaker, Dr. Shivangouda. Dr. Shivangouda, welcome on behalf of NNF Karnataka.
Thank you, sir.
He has been working in Gadag and he has been a great inspiration for many. And being an young dynamic person, he has taken up the role of service and he has been instrumental in many of the government projects. Thank you very much for serving the people of Karnataka at your place. It's a great inspiration and it's a great honor to welcome for our NNF Karnataka e-web series. Thank you very much for accepting our request.
Thank you, sir.
So today, welcome. Today, we have two most important topics as a practicing neonatologist and a pediatrician practicing neonatology. It is a two important things which we worry about when extreme premature baby gets admitted in an ICU. That is intraventricular hemorrhage, the long-term implication of premature brain and the complication related to prematurity over the brain, the periventricular leukomalacia. The first topic will be done by Dr. Shivangouda on the IVH and PVL prevention, treatment and follow-up part. And followed by that, I'll be doing the ultrasound findings of IVH and PVL. So I was forced to do because the end moment, one of our speakers, because of the very serious thing, was unable to do it. No problem. So much. Thank you very much. Now I request Dr. Shivangouda to start the session. Over to you, Dr. Shivangouda. And I request all the participants to please mute your audio and video both. I request all participants to mute audio and video both. Over to you, Dr. Shivangouda.
Okay, sir. So good evening, everyone. Good evening, everybody. I thank NNF Karnataka President, Secretary and NNF Core Committee members for giving me an opportunity and representing our SNCU Gadag in this e-forum. Thank you all. So slides are not moving.
Yeah.
Introduction. Yes. Preterm brain injury remains a great challenge in neonatal medicine, and these children now constitute the majority of children with cerebral palsy. In very low birth weight babies, 5 to 10% will present with major motor deficits, 25 to 50% with cognitive, behavioral, attention, and socialization defects. Cognitive defects without major motor defects are now the dominant neurodevelopmental sequelae in the survivors of early preterm birth. So just I want to share my own experience when I joined this SNCU Gadag 2.5 years back. So first week I got a baby which was 760-gram baby. So during that time we have only warmers and oxygen. I was about to refer this baby, but the parents were very reluctant. They told that whatever is available here you do, we don't want to go anywhere. So that time I used indigenous CPAP with the oxygen tubings. I dipped in the water and given CPAP and used feeding tube as a central line. So it was a very crude method. We managed this baby and the baby survived. The sisters were very happy, but I was not happy because we are not giving a quality care. Just survival is not important, but intact survival is very important. And that baby developed ROP and laser treatment was given. Hearing deficits were there and baby had little hypertonia. MRI we did, it was abnormal. So we have to improve. So now we have been improved and now we have around 16 bedded NICU which has 7 ventilators, 2 high flow nasal cannula and then 15 bedded KMC unit. So just I am presenting the data. So normal data where we had 1,825 admissions, in that 70% of the babies we have discharged and 20% we are referred within the Gadag to scheme hospitals. It is done at free of cost. So if we see 2 years back, no babies were getting admitted less than 1 kg. So now we have 33 admissions were there last 1 year and 6 babies we have discharged, and we are doing follow-up of those babies also. So this is the data, Vermont Oxford network data. It is showing that less than 1.5 kg babies, 20 to 25% is the incidence. So we should have an uniform data. So all the SNCUs, we are collecting the data in terms of mortality and morbidity. We have to intensify it because most of the NICUs doesn't have ultrasounds to check whether there was an intraventricular hemorrhage or PVL. Presently, we got an ultrasound machine, echo probe also, and DM neonatologists have joined our unit. In further, we are getting this data, how many babies had IVH and PVL. The site of intraventricular hemorrhage, the most common site is subependymal germinal matrix. So this is the area where there will be proliferation of pre-oligodendrocytes will happen in the early trimester. Later, this width gone reducing, it becomes 2.5 millimeter by 20 to 23 weeks, then 1.4 millimeter by 30 to 32 weeks. Slowly, it will involute by 36 weeks. If you see at 28 to 34 weeks, if you see hemorrhage, we will see at the thalamus-triadrau at the level of head of the caudate nucleus, and less than 28 weeks also on the body of caudate nucleus. This will be dealt in detail by PRASHANTH GOWDA sir during ultrasound class. So there are many pathogenic factors. So there are vascular and intravascular factors, the anatomical factors, because the vascularity, but at that area, the capillaries are very fragile, tenuous capillary integrity, which is vulnerable for injury. And extravascular factors, that is deficient vascular support, decreased fibrinolytic activity, and postnatal decrease in extravascular tissue pressure. So intravascular factors, fluctuating cerebral blood flow. So in a severe preterm RDS baby, increase in cerebral blood flow, systemic hypertension, rapid volume expansion, hypercarbia, decreased hematocrit, decreased blood glucose, increase in cerebral venous pressure, decrease in cerebral blood flow, that is ischemia followed by reperfusion, platelet and coagulation disturbances. So if you see fluctuating in the cerebral blood flow, when there is a stable cerebral blood flow, the incidence of IVH is less compared to that of the fluctuating cerebral blood flow. So it happens in an extreme preterm baby where there are chances of hypercarbia, hypovolemia, hypotension, and increased FiO2 concentrations, which will alter the cerebral blood flow, and chances of IVH will be high. So when the mean arterial blood pressure increases, there will be increased cerebral blood flow. This is due to pressure passive circulation. So the cerebral autoregulation in these preterm babies is very poor. Whenever there is an increase in the mean arterial blood pressure, there is increase in the cerebral blood flow and intraventricular hemorrhage will happen. So the major causes for increased cerebral blood flow, the physiological events, REM sleep, postpartum status, and caretaking procedures, noxious stimulation, motor activity, spontaneous or with handling, tracheal suctioning, installation of mydriatics, systemic complications such as pneumothorax, rapid volume expansion, exchange transfusion, ligation of patent ductus arteriosus, neurological complications, seizures also increase the mean arterial blood pressure and increases the cerebral blood flow. So if you see in this picture, changes in blood pressure with tracheal suctioning. So whenever at the rest, the blood pressure is mean arterial blood pressure is 25 mmHg. When you do tracheal suctioning, the mean arterial blood pressure will start increasing and it will start shooting up, and it increases the cerebral blood flow and causes IVH. And impaired autoregulation with hypercapnia, permissible hypercapnia 45 to 55 is acceptable, but once PCO2 starts increasing above 45, there will be increased cerebral blood flow and chances of IVH is high. So in case of the mode of delivery, route of delivery, if you conduct a vaginal delivery, in a preterm baby, in a breech delivery, if it is more than 12 hours, the chances of IVH is there because of increased cerebral venous pressure compared to that of the LSCS. Later in future slides, we'll see the evidence whether can we go for vaginal or cesarean section in these preterm babies. So neuropathological consequences of intraventricular hemorrhage. So germinal matrix hemorrhage, it is the site where the pre-oligodendrocytes will proliferate and it will migrate, and then it will differentiate and myelination will form. So when there is a destruction to this germinal matrix, there will be destruction to oligoprogenitor cells. So there will be decreased mature oligodendroglial cells and decreased myelination and axonal dysmaturation will happen. And these GABAergic neurons, they are the late GABAergic neurons which will be migrating. So that also will be destroyed, and this will cause cerebral cortex and thalamic dysmaturation. So whatever the free iron is left after the hemorrhage, so it will cause reactive free radical injury and then further injury to oligoprogenitor cells and axons. So the blood which is collected in the posterior fossa, so it will coat the cerebellum. So iron that is present, it will cause free radical injury to the external granular layer, and also the cells which are present moving towards the inner granular level, differentiation also will be less. The cerebral pontile volume will reduce and there will be cerebellar dysmaturation. So periventricular hemorrhagic infarction usually associated with intraventricular hemorrhage. So sometimes they are considered in grade 4. Actually, the mechanism is different. So germinal matrix hemorrhage, it will cause periventricular venous congestion, which will cause periventricular ischemia, and there will be periventricular hemorrhagic infarction. So whatever the hemorrhage is there, it blocks the, it causes obstructive hydrocephalus also by blocking the arcuata villi, or it will block the aqueduct of Sylvius. There will be progressive ventricular dilatation slowly in 25% and non-progressive in 25%, and there will be no ventricular dilatation in 50%. So clinical features, there will be, it presents as 3 syndromes: catastrophic syndrome, saltatory syndrome, and clinically silent syndrome. So least common is catastrophic syndrome. The babies will present with deep stupor, coma, respiratory abnormalities, generalized tonic seizures, pupils fixed to light, and there will be flaccid quadriparesis. Saltatory syndrome, which is more common, stuttering evaluation, it takes hours to days. There will be alteration in level of consciousness, hypotonia, decrease in spontaneous and elicited motility, aberrations in eye position and movement. So clinically silent syndrome, the most valuable sign what we see here is unexpected fall in the hematocrit or failure to rise hematocrit even after the transfusions. So prognosis, short-term prognosis, it depends upon the severity of hemorrhage and prematurity. So grade 3 and apparent periventricular hemorrhagic infarction, so less than 750 grams, there are 45% deaths, and in 750 to 1500, 22%. So progressive ventricular dilatation in less than 750 grams, it is 83%, and 66% in 750 to 1500 grams. Long-term prognosis, they present with spastic motor deficit or major cognitive deficits. So grade 3 and periventricular hemorrhagic infarction incidence is 75% compared to grade 1, it is 15%. So review of children with periventricular hemorrhagic infarction treated in single unit from 1999 to 2012. So where they followed up the babies, where there was parietal periventricular hemorrhagic infarction, 50% developed cerebral palsy. So frontal, they developed cognitive, behavioral, and visual problems, and temporal also unilateral cerebral palsy 10%, and remaining they developed cognitive, behavioral, and visual problems. So we'll be discussing the prevention and all together with PVL and IVH. We'll discuss together. So now we move on to periventricular leukomalacia. So periventricular leukomalacia, it is multifocal areas of necrosis forming cysts in deep periventricular cerebral white matter, dorsal and lateral to external angles of lateral ventricles. It is often symmetric. There are 3 types are there: cystic, which is most severe, Non-cystic is intermediate. Diffuse white matter gliosis mildest. So incidence of PVL, cystic PVL is seen in 3 to 5% of very low birth weight babies, and diffuse non-cystic lesions ranges from 20 to 50%. The risk factors associated with periventricular leukomalacia are in pregnancy with multiple gestation, prenatal factors like IUGR, abnormal placenta or cord insertion, maternal infections, long rupture of membranes when there was no antenatal steroids were given. Perinatal factors include placental abruption, maternal hemorrhage, abnormal fetal heart rate tracing, fetal acidosis, and neonatal factors include infection, inadvertent hypocarbia, hypotension, vasopressor requirement, PDA, necrotizing enterocolitis. PVL may be late finding after surgery or sepsis. So pathogenesis, if you see PVL, it is a multi-hit hypothesis. It is not only the single cause. The most commonly here is the anatomical factors, which there will be terminal end vessels around the periventricular region, more prone for ischemia and reperfusion. When the primary injury happens, primary ischemia, there will be decreased in oxygen, there will be increase in lactate, primary energy failure, and the cell death will happen by necrosis. Following it, the secondary mechanisms will get activated by increase in the glutamate, the caspases, endonucleases, and the oxidative stress, which will cause injury by secondary mechanisms, and there will be apoptotic cell death will happen. So other mechanisms are if there is a maternal infection or fetal infection, so it produces inflammation and there will be cytokines will be released, so that increased glutamate, again it will cause injury to the cell. So intraventricular hemorrhage, the iron released from the hemorrhage, it will also cause free radical injury to the cells. So if you see a hypoxic ischemia, pancellular death, like by primary necrosis and secondary by apoptotic death, both will cause impaired myelination. Neuropathology of periventricular leukomalacia. So pre-oligodendrocyte injury will happen. So this will cause decreased myelination and cortical and thalamic development. Axonal injury, which will cause decreased myelination and cortical and thalamic development. And thalamic injury also decreases the myelination, decreased cortical development. Subplate neuron injury, so it will cause decreased myelination. And migrating GABAergic neurons, which will cause decreased cortical development, mainly the upper cortical layers. So PVL types, classical cystic, it is focal macroscopic periventricular necrosis in the deep cerebral white matter, a trigon of lateral ventricle and foramen of Monro. This coagulation necrosis followed by cyst formation over 1 to 3 weeks. Multiple small cysts more than 3 mm is detected by ultrasound. So this will be dealt in detail by Prashanth sir. Diffuse cerebral white matter, it will be less severe and widespread, and there will be ventriculomegaly and decreased white matter volume. So if you see prognosis, so in the neonatal period, so you may see lower limb weakness and long-term sequelae are spastic diplegia, motor deficits, cognitive deficit, visual deficit, behavioral and attention deficits. So if you come to preterm brain protective practices, so prenatal interventions are prevention of preterm birth, so optimal management of labor and delivery, in utero transport, pharmacological, steroids, phenobarbital, vitamin K, and max sulfate. So postnatal interventions, neonatal preventive practices, pharmacological interventions, phenobarbital, indomethacin, vitamin E, and ethamsulate. Now we will see the evidences for it. So prevention of preterm birth. So three major approaches is identification of the women at high risk for premature delivery. We have to see whether there is a previous preterm delivery or IVF conception, and also we have to identify them who are high risk, and we have to educate them treatment of infection and comprehensive health care. Early prevention of labor, so we have to give primarily tocolytic agents. So, and there is a study on systemic review of use of progesterone. So if you give progesterone during second trimester of pregnancy, so where previously they will have preterm deliveries, so it has reduced the chances of preterm delivery before 32 weeks and reduced perinatal death, RDS, and necrotizing enterocolitis. So Cochrane review about cesarean section and vaginal delivery. So there is no enough evidence to evaluate the use of policy of planned immediate cesarean delivery for preterm babies. 4 studies they have analyzed, and the relative risk was 0.92%. So it doesn't provide any evidence like you have to go for cesarean section only. So, however, in breech delivery, when there is a prolonged delivery, it is better to go for cesarean section. One study is shown. So, effect of transport. So, whether to better to have in vitro transport. By this study, we will know the chances of intraventricular hemorrhage was 25% compared to outborn babies. It is 55% because when they are delivered outside, there will be the resuscitation measures and the transport from one place to another place. It will be hindrance, so there will be high chances of intraventricular hemorrhage. So better if you are expecting a preterm delivery, transport in vitro only to the center where they can manage these preterm babies properly. So about antenatal steroids. So antenatal steroids. So results on IVH, when you use steroids, it reduces the incidence of any grade of IVH, and there is a reduction in incidence of severe IVH also. This association was seen across the gestational age ranging from 22 to 29 weeks. So antenatal steroids will reduce the chances of periventricular leukomalacia also. There is 50% reduction in incidence of periventricular leukomalacia in these preterm babies. So increased use of antenatal steroids will improve the neonatal neurological outcomes. But the SUOG committee will tell only single course is recommended. So repeated courses of steroids are associated with high risk of cerebral palsy in infant in one study and maternal HPA suppression and increased risk of infection. So betamethasone or dexamethasone, both decreased incidence of IVH will with dexamethasone, whereas less frequent adverse neurological outcome at 18 to 22 months after betamethasone use. But there are inconsistent and limited data recommend for one steroid over the other. Use of phenobarbital. So prophylactic maternal phenobarbital for preventing IVH. So it doesn't provide any evidence in preventing periventricular hemorrhage in preterm infants, nor from neurological disability in the childhood. So it has caused more of maternal sedation. So use of phenobarbital is not recommended. So use of vitamin K prior to preterm birth for preventing IVH. So Cochrane review 2010 shows no significant evidence in preventing periventricular hemorrhage in preterm infants or improved neurodevelopmental outcomes in childhood. So use of vitamin K is also not recommended. So about use of magnesium sulfate for women at risk of preterm birth for neuroprotection of fetus. So Cochrane review 2009. So 5 randomized controlled trials have done. It reduces the incidence of cerebral palsy. The number needed to avoid CP is 63. The neuroprotective role for magnesium sulfate therapy given to women at risk of preterm birth is now established. But the later outcomes need to be evaluated. So most mechanism is it reduces post-hypoxic brain injury in perinatal period by blocking excess release of glutamate. So now WHO recommendation is also there for the use of magnesium sulfate for neuroprotection of these preterm babies. So they made 3 dosing regimens. So it depends upon the unit, whichever they want, they can use the dosing regimen. So about maternal antibiotics and periventricular leukomalacia in case of infection. So in a study, it showed that so maternal antibiotics were associated with decreased risk of cystic periventricular leukomalacia. So maternal antibiotics do not change the risk of cystic PVL. Maternal antibiotics decrease the risk of cystic PVL, but did not change the risk of mortality, sepsis, or severe intraventricular hemorrhage. Neonatal preventive practices such as cord clamping, neonatal resuscitation, avoid fluctuating of cerebral blood flow, correction of fluctuations in cerebral blood flow velocity, correction of abnormal coagulation. So neonatal care practices such as minimal stimulation, NIDCAP trial, ventilation and surfactant protocol, caffeine, doxaprom, early erythropoietin therapy, aggressive nutrition. So we'll see the evidences for it. So delayed cord clamping in preterm babies, it reduces the incidence of intraventricular hemorrhage and late onset sepsis. So delayed cord clamping for 30 to 45 seconds has reduced the incidence of EVH and late onset sepsis. So even NRP recommendation 7th edition, so it will shows that you should delay cord clamping for 30 to 60 seconds for most vigorous term and preterm newborns. So if there is a placental circulation is not intact in case of abruption or bleeding placenta previa, immediately you should clamp the cord. But there is insufficient evidence to recommend an approach to cord clamping for newborns who require resuscitation at birth. Studies are going on, as Archana Madam has given detailed explanation about this delayed cord clamping in her previous classes. So prompt resuscitation as per NRP, avoid hypercarbia and hypoxemia as well as hyperoxemia, avoid rapid boluses, avoid rapid soda bicarb. So NICU characteristics also affects the intraventricular hemorrhage. So the incidence of grade 3 to 4 IVH in the NICUs were ranging 2 to 20.5%. So it was where the NICUs have high patient volume.
Kindly unmute. Shivu, kindly unmute.
So even the NICU characteristics will affect the IVH. So where the NICUs which have high neonatologist staff ratio add lower rates of severe IVH. Prevention and treatment of hemodynamic aberrations. So minimal stimulation bundle, you should avoid apneas, acute hypercarbia, pneumothorax, suctioning should be quick, rapid transfusions we should not do, and exchange transfusions also will cause PVL. So if you see the short and long-term outcomes for very low birth weight babies in Edmonton NIDCAP trial, so NIDCAP based care for very low birth weight infants have improved the short and long-term outcomes significantly, though it didn't reduce the incidence of IVH. So we have done a similar study where there is an early parental participation in Kerala Institute of Medical Science, Trivandrum, where I did my fellowship under Dr. Naveen Jain. So we see in the physiological stability in preterm babies. So later next paper is about the neurodevelopmental outcome. So here also physiological stability was 46% compared to 66%. So when we were doing fellowship, so it was very uncomfort initially when the father also used to enter the NICU from day one. So he used to accompany the babies. So during that time, we fought with sir so much that it will increase the sepsis and it becomes very uncomfortable to work and all. But somehow sir convinced us, so told that we'll see the sepsis rate in early parent and conventional parent participation. So when we analyzed the data, we saw that there is a reduction of sepsis where there is an early parental participation. And the explanation what sir gave was, see, it is one baby for them. So if I tell them to wash hand properly, they will do it 100%. So healthcare staff, you have so many babies. So this was the explanation given by Naveen Jain sir. So today we are seeing the results very nicely when we started this study. So even the PVL at 37 to 40 weeks, it is a small study, 2.73% compared to that of the conventional care, it is 4%. So still more studies have to come and the data should be more. And next paper, this we are given this for European Journal of Pediatrics for publication. It has yet to be published. And neurodevelopmental follow-up in early parental participation, that also paper yet to come. So nasal CPAP and intraventricular hemorrhage, very low birth weight babies treated successfully with early nasal CPAP, chances of developing grade 3 and 4 IVH is less in those babies. So we should practice early CPAP. So mechanical ventilation, severe IVH was associated with very low birth weight babies, mechanical ventilation in delivery room, and cumulative duration of ventilation in the first 3 days. Whereas the risk of IVH in infants who never intubated in the delivery room or during first 3 days of life is little bit less compared to that of the intubated babies. So hypocapnia, so PCO2 less than 25 mmHg is associated with high risk of cystic PVL. Permissive hypercapnia, 45 to 55 PCO2 levels are accepted, but levels above 55 is not recommended, high chances of intraventricular hemorrhage. So if you see in this graph, so when the PCO2 levels above 75th centile, 4.6 times greater the odds for intraventricular hemorrhage. So timing of surfactant, so early surfactant versus late surfactant. So early surfactant group had lower rates of pneumothorax and intraventricular hemorrhage grade 3 or more when compared to late surfactant group. And less invasive surfactant administration in extremely preterm infants. So surfactant can be significant survival rates and significantly less IVH, less intraventricular hemorrhage, and cystic PVL in using LISA technique. However, PDA and ROP occurred significantly more common. So about the nutrition, so high initially they thought that high dose, if you give amino acids, so it will reduce the chances of PVL. So the review, it will tell that, so dose of at least 1.5 gram per kg per day, and the maximum dose is 2.5 to 3.2 gram per kg per day. So if the protein, if you are giving more than 3.5 gram also, so it is the same. So it is not advisable to give more than 3.5 or 4 gram per kg per day. So randomized trials comparing 1.5 gram per kg per day within 48 hours, increasing to 3.5 to 4 gram per kg per day versus 1 gram per kg per day, increasing slowly to 2.5 gram per kg per day, showed no major difference unless combined with aggressive enteral nutrition. So enteral nutrition is very important along with the TPN. Postnatal nutrition and brain development data support that critical period of nutrition for brain growth and synaptic expansion during the first 6 to 12 months of life. Studies in preterm infants post-discharge have shown improved OFC and growth by 1 year with enriched formula. So, CAP trial, so caffeine therapy for apnea of prematurity. So there is significant improved rate of survival without neurodevelopmental disability at corrected age of 18 to 21 months. So reduced incidence of cerebral palsy and cognitive delay. The mean mental development index score on the Bailey test and mean psychomotor index score was high in caffeine group. So we conducted a similar study, long-term mental outcome of caffeine versus aminophylline therapy for apnea of prematurity in KMC Manipal when I was a postgraduate. So we started this study and it was continued by our junior Sujit, and this has been published by our guru Dr. Leslie Lewis. So this results show that 83% less risk of getting cognitive impairment, where the relative risk is 0.16, and 24% less risk of developing motor deficit, and 24% less risk of developing language problems. Effect of early prophylactic high dose recombinant erythropoietin in very preterm infants on neurodevelopmental outcome at 2 years, the randomized control trial. The conclusion, it shows that there is no statistical significant differences in neurodevelopmental outcome at 2 years. About prophylactic IV indomethacin, the Cochrane reviews will tell there are short-term benefits of reduction in incidence of symptomatic PDA, PDA surgical ligation, and severe intraventricular hemorrhage. So, however, there is no evidence of effect on mortality or neurodevelopment. Ethamsulate for prevention of intraventricular hemorrhage in preterm of low birth weight infants, the Cochrane review 2010, there is reduction in incidence of any degree of IVH by 37% in infants less than 31 weeks or 1,500 grams, no reduction in mortality or neurodevelopmental impairment despite the reduction in any grades of IVH. So vitamin E, Cochrane review 2003, it will reduce the chances of intracranial hemorrhage, severe retinopathy and blindness. However, it doesn't support, the evidence doesn't support the routine use of vitamin E supplementation by intravenous routes at higher doses or aiming at serum tocopherol levels greater than 3.5. So now we will see evidence-based practices. So routine LSCS, still it is controversial, still more studies has to come up. So in vitro transport, yeah, we have to do in vitro transport for reducing the intraventricular hemorrhage and PVL. Steroids, yes, we should give antenatal steroids, and magnesium sulfate. So we should give magnesium sulfate. It has potential benefit in reducing the PVL. And phenobarbital, no evidence. Vitamin K, there is still no evidence. So delayed cord clamping, yes. So minimal stimulation NIDCAP, yes. Early CPAP or insure technique, yes, there is an evidence. Early surfactant therapy, yes. CO2 control, yes. Aggressive nutrition, yes. Caffeine, yes. Still there are no relevant studies for phenobarbital, use of phenobarbital, indomethacin, vitamin E, ethamsulate, and repeated helps for progressive hemorrhagic hydrocephalus. So this is the baby. So first baby, we told the first baby 760 gram, where we survived when we didn't have any facilities, only oxygen and warmer was there. But that baby developed ROP, hearing deficit, and there was neurodevelopmental defects were there. But this baby, 560 gram baby, it was a 26 weeks baby, which we survived. At that time, this time we had everything. We have surfactant, we have 7 ventilators, we have high flow nasal cannulas. So this baby, we were able to survive, and we celebrated 1 year birthday also. So presently this baby is like this. So 26 baby, the birth weight was 560 gram. Now it is 15 months baby with corrected gestation age 12 months. So it has normal vision, hearing. So, and the baby is now able to walk with support. So we should now aim towards normal. Just survival of preterm babies is not enough. Just neurological intact survival of these preterm babies is very important. So now in all our SNCUs, we have to look up at the data every month so that it will boost us. How can we move further? So how can we improve our SNCUs? How can we fetch the data? So with this, I will end my talk and just an message to the neonatology fellows who are just finishing. So if you want to change the numbers, if you want to see the numbers reduction in neonatal mortality in Karnataka, these are the places where you have to work. These are the SNCUs where if you put your efforts, we can reach our goal, single digit neonatal mortality rate. So, and it is when I started work here, so Dr. Naveen Jain sir and Dr. Leslie sir supported me so much. They told me, so when I was working, so they told their inspiration words were, so we have trained you not to work in the NICUs, we trained you to create the NICUs. And I'm very thankful to my teachers. And Naveen sir told always it is the hard work which will not fetch the success. So it is the happy working environment, what you create around you, that will lead to the success. Thank you.
Thank you, Dr. Shivu. Wonderful presentation. You have covered with all the latest evidence and you have put so much hard work. It shows fantastic presentation and you shared your experience as well working in the rural areas, how tough it is and how to handle it. So thank you very much. A big thanks. And it is now, my part is on the ultrasound evaluation of the IVH and Pvl. So after this session, then we take up discussion part. So I request all the participants to kindly pose the question so that we'll take up for discussion at the end of. So once again, thank you very much for joining. So I took up this topic because of one of our speakers at first. That's why he could not do this. No problem. So again. So I'll be talking on intraventricular hemorrhage and critical leukemia and the findings in ultrasound. So this is a very common of what we see in our good evening, everyone. Am I audible?
Yeah. Yes, sir.
Is my slide visible?
Yes, sir, visible.
Okay. Yeah. So today my topic is intraventricular hemorrhage. Thank you very much, Dr. Shivu, for your wonderful presentation. So,
thank you.
You
sorry, there was video was not there.
Okay. Sorry, Shivu.
Sir, video was not there. Sorry for all members. Only I can present.
It's nice that you shared your experience, how it feels like working in a setup with very minimal infrastructure and how you can build it up. So it's a wonderful work you have done from no ventilator to you have brought the ventilator and you have created the NICU in your city. Thank you very much for serving the people. So my topic is IVL, IVH and PVL on ultrasound. So the slide moving now. Okay, the load more.
No, sir. Slide
moving?
No, sir.
Prashant, the slide is not moving.
Slide is not moving.
Yes, sir. Yeah, I can hear. Sir. 1 second. Sir.
Because you have to start.
Microsoft Team, you always have. Sharing. Just stop sharing, sir.
ಪ್ರಶಾಂತ್ ಒಂದೊಂದ್ಸತಿ ನೀವು ಮತ್ತೆ ರೀಲೋಡ್ ಮಾಡಿದ್ರೆ ಹೋಗುತ್ತದು.
ಇಲ್ಲ ಸರ್, ಈಗ ಇನ್ನೊಂದರಲ್ಲಿ ಸ್ಟಾರ್ಟ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. Yeah. Yes, is it changing now?
No, sir. Not changing.
Sir, meanwhile, you can just start the discussion. Yeah, it has come. It has changed now. It has changed. Yeah. It's changing now. So, good evening, everyone. I'll be talking on IVH and PVL. Let us move to the topic quickly. So before ultrasound views, you need to have a clear idea about the anatomy of the brain. What are the structures which we see? What are the structures which are present, and how it looks in ultrasound? It will be easier once you have an idea about the anatomy of the brain. Yeah. So I want all of you to have a close look on this anatomy. There's an anterior view where you're standing right in front. How the inside of the brain looks. There is a superior view where you are seeing the by looking through the top of the head, and there is a lateral. So inside the brain, these are the structures which are present. From medial to lateral, we have. This is your cerebral fissure or anterior median fissure. You have corpus callosum from medial to lateral. Then you have ventricle, which is green in color. Then you have green color. That's your caudate nucleus. How it looks anteriorly when you stand in front of the brain. So I always tell that you cut an apple and try to see from the front. You'll see division when you cut from the top, and you have a seats on either side. That is the ventricle, how it looks in a coronal plane. So this is the anatomy of the brain from the anterior view. You have anterior median fissure. You have caudate, and the green color which is there in between corpus callosum and the blue color, that is your ventricle. So moving on to the superior, you are standing and you are visualizing the brain. So this is the superior view. I
खत्म हो गया. हाँ. खेल खत्म हो गया.
I request participants to kindly mute. Yeah. So this is the superior view. As I said, caudate, corpus callosum, ventricle, then caudate nucleus in the anterior part. This is the anterior part face, and this is thalamus. Then we are standing on the side of the brain. How it looks. The green color one, what you are seeing is your anterior arm, body, then you have occipital arm, and your temporal arm. Temporal arm sits on the temporal lobe, the down one. You can see it as a, you have your anterior arm, then you have your occipital arm, and then you have your. So below that, you see a structure called fornix, and then you have foramen Monro here. Then you have a third. One second. Yes. So this is the anatomy, and then you have your lateral view, the D, that is the lateral view, what you see. So this is the superior view where we have taken we are viewing the thing from the top end. So you can see inside the lateral ventricle. This is your corpus callosum, what you see here, the front part CC, what is written. Then something is open here, that is your lateral ventricle. And inside lateral ventricle, you can see a worm-like thing, that is your germinal matrix. On the right side of the lateral ventricle, right lateral ventricle, we have removed that germinal matrix and you can see the choroid arteries. So this is how it looks like in the anatomy of the brain. So next, moving on to the marker what I have put, that is your choroidal artery. On either side, you can see a worm-like thing inside the ventricle. That is your germinal matrix. So which is there from the lateral ventricle, moves through the foramen Monro into the third ventricle and then into the fourth ventricle. So bleed can happen anywhere. So this is the venous system. On the superior view, how it looks. So I would want you to see the next slide, which is coming up now, wherein the venous drainage. So when we talk about the intraventricular hemorrhage, apart from the bleeding of germinal matrix, which feeds and compresses the venous system, and then that causes periventricular hemorrhagic infarction. So this is the slide which you can see now with an venous angle which is written over. And if you follow that, there is ICV, that is internal cerebral vein, which is moved and drains into the great cerebral vein, also called as vein of Galen, and then that drains into straight sinus, and then into the sigmoid sinus, then into your internal jugular vein. This is how the drainage happens. And then you can see one more below the venous angle, we have written BVR. On the superior surface of the temporal horn of the lateral ventricle, drains again into the great vein of Galen, and then into the straight venous, sigmoid sinus, and then it moves down. This is the place where the venous angle is the place where the caudothalamic groove is present, and if any bleed is there, especially when acute bleed happens, it compresses this venous angle and then causes hemorrhagic infarction. The area, complete area of inferior get infarcted from anterior to the posterior. So now I'm going to play a video with you an idea about the internal cerebral and then how it looks inside the brain. So once you capture this image in your mind, then it's easy for you to understand ultrasound. Yeah, so this is the video which is coming up. Yeah, I think same problem with what Shiva had. The video is not playing. Anyway, we'll move on to the next slide. This is about the incidents which has already been covered by Shiva about the intraventricular hemorrhage. I don't want to talk about it. We'll straight away move into cranial ultrasound screening, which is coming in your slide next.
அது வந்து ஹார்ட்லியா ஒரு நான் சொல்றேன் இல்ல இல்ல
Slide is moving. No, next slide.
Prashant?
Yes, sir. Yes, sir.
If video is not playing, you go ahead. Don't stick on to video, dear.
No, sir. It's actually when I change, it takes around 6 seconds. Anyway, I'm moving to the next topic, sir.
No. Prashant, what happened is everywhere Microsoft, what we are using, whole India, there are another 18 people are doing. Everybody is having the same problem. Nobody is able to join, including me. You understood? No, not only as there is some problem with the Microsoft. So you go to the internet and check it. Now they are Microsoft and some China. Something is happening because Zoom people and this. So you go ahead and start doing. Later we will see.
Yes, sir. Yes. So this is the screening protocol, a simple one which you can remember easily. First cranial ultrasound if baby is less than 32 weeks, baby is on a ventilator, or any high-risk baby where there is a risk of intraventricular bleed. This is the protocol. On first day, within 24 hours, get the first cranial ultrasound done. Within 3 days, get the second cranial ultrasound done. And within 7 days, get the third screen done. Because 90% of the bleed, intraventricular bleed, will develop within 3 days, and maximum within by 1 week, all the progression and the severity we will come to know by 1 week. That's why within 24 hours, if you do one scan, the second scan on day 3, the third scan on day 7, and most of the bleed, as I said, by 1 week you'll be able to get an idea. So next we'll move on to the ultrasound section about how IVH looks. This is the coronal section. So I was talking about cutting an apple. If you cut an apple and stand in front of the brain, this is how it looks like. That is called coronal plane, where you can see the red color bindi which is put on the center of the brain below the caudate nucleus. That is, and the thalamus nucleus. That is the bleed. So simultaneously we have put on the right side the ultrasound picture of coronal plane. The probe is put on B. What is written here? That is the marker. Then you have a center anterior median fissure or intercerebral fissure. Then you have cavities to both the sides. That is your lateral ventricle, anterior arm of the lateral ventricle, and 2 arrows have been put in yellow color arrows. That is the bleed which is present in the coronal section. So this is how it looks like germinal matrix bleed or intraventricular hemorrhage. How it looks in the coronal section when you at the level of foramen Munro. Next, we'll see how in sagittal section the bleed looks. So the next upcoming slide, I will be showing you on how in sagittal plane it looks. So if you cut a brain and if you stand on the brain, that is what is your, and when you view the brain, that is what is your coronal plane. So next slide. Yeah. So this is the sagittal section. You can see on the side the red color thing, what you see as a bindi, now you are seeing exactly anteriorly caudate nucleus, which is written, name, labeled. Posteriorly, there is a thalamus, which is labeled, and in between, you can see a red color, oval shaped red color thing, that is your bleed. Same similar picture in ultrasound, how it looks, they have put on the right side, marked by an arrow, yellow color arrow, that suggests the how the blood bleed looks. So you can see the caudothalamic groove, there is a bump which is seen in the caudothalamic groove. So this is how it looks like, the grade 1 bleed, which it looks like in ultrasound. So now we'll move on to the grading. Earlier in 1978, Pvl graded the IVH intraventricular bleed into grade 1, 2, and 3 and 4, which is not being followed now because this is how. So here is classified as grade 1, 2, and 3, 4. So we don't follow this. We follow Volpe's classification. That is the latest one, which gives the estimation of the bleed and quantify the approximate quantify the bleed. So if there is some bleed, is there right? It makes no sense. We need to give what percentage of the ventricular system it covers. So few things which before going into the Volpe's classification in cranial ultrasound, whenever there is an acute hemorrhage, if bleed is not, care should be taken not to diagnose acute hemorrhage if the bleed is not highly echogenic. So if bleed is resolving, you see if the clot is retracting, you see the edges being hyperlucent, the center being echolucent. Hyperlucent, you see this. These are the two things which you need to remember. Now moving on to the Volpe's classification. Volpe is very simple. They've got 3 grades. This is done in 1989. So there is a germinal matrix swelling in the caudothalamic groove with no or minimal bleed. Even if there is a bleed and if it is covering only 10% of the ventricular area, we call it as grade 1. In grade 2 bleed, there is a bulging, rupture of the germinal matrix, and the bleed covering 10 to 50% of ventricular area on a parasagittal view. That is what grade 2. In grade 3, if the bleed inside the ventricular system covers more than 50% of the ventricular area, we call it as grade 3. Grade 4, which was earlier there in Pvl, has been made because it's not a bleed. Because whenever the acute grade 1 bleed happens, which I was talking about, the venous angle, the terminal vein, the venous angle, that gets compressed, and the part of area which it drains the veins drains the part of the brain gets infarcted. So we call it as post-hemorrhagic venous infarction, PHVI. So that is the thing. Now this is the schematic or diagrammatic representation of the bleed. We'll take one bleed at a time with ultrasound and how it looks. Just to give a glimpse of it, I've put all the bleeds together. There is a small bleed which you can see as a dot. That is a grade 1. Then there is a grade 2. Then grade 3. And histopathologically how it looks, the grade 1, 2 and 3. When you cut the brain, when you actually see the brain, how it looks, that will be the next slide. This is the slide. So you can see a small bleed below the lateral ventricle in the caudothalamic groove. In grade 2, you can see how the blood has spilled into the ventricle with ventricular dilatation. On grade 3, you can see how the blood has covered the major part of the ventricle. And in grade 4, you see grade 4 is nothing but Thank you. So on grade 4, whenever there is acute bleed compressing on the terminal vein, it causes infarction. You can see over there a big cyst which has formed. Now moving on to the grade 1. As I said, that will be the next slide which will be coming up now. As I said, in grade 1, you see the bleed bulge in the germinal matrix and minimal or no bleed into the ventricular system at cardothalamic notch. See, before at 32 weeks, you see at cardothalamic, when you take the germinal matrix, how it appears from 20 weeks to 34 weeks, you see that around 28 weeks, up to 28 weeks, it covers the lateral ventricle, the third ventricle, and the fourth ventricle. Basically, entire ventricular system, germinal matrix will be there. It's a gelatinous glial cells from where the cerebrospinal, development of the brain happens. It's like a pluripotent stem cell. What we have, germinal matrix is like that. So it produces all type of cells for the brain development. So it is present in all the ventricular system. So in cardothalamic groove, you can see a minimal bleed on the sagittal section of foot and the coronal section. The first two picture, what you see is the schematic representation and the ultrasound representation of grade 1 bleed. The bingy type thing, what you are seeing, that is your grade 1 bleed, where it is restricted to cardothalamic groove with minimal or no bleeding in the ventricular inside the ventricles. So the next slide, which I'm going to put, is the what is a pitfall in the diagnosis of grade 1 intraventricular bleed. You have a small echo dense structure below the ventricle marked by thick yellow arrows. You can see there. It appears in one section, it appears like the next slide, which we have taken a sagittal section. You can clearly see the groove, cardothalamic groove, a dipping groove present. So this is the thing, you know, if you are seeing, and if the experience is very minimal, or if you have put the gain high, or if you have increased the gain, and then when you see, this will appear like a bleed. That's why in our practice, most of the radiologists, when they see this particular echo dense or hyperlucent structure marked by thick yellow thing in the first slide, they give in the report as grade 1 bleed. But actually, when you take it in sagittal section, you can clearly see the cardothalamic groove dip. So that is, if the dip is there, that usually rules out the confusion what we have in our coronal section. So it is not a bleed. This is a pitfall which we need to remember when you are scanning the baby. So the next one, which I'm going to put, so people can actually in the chat, they can mention. I've put two things. Can somebody tell me that the picture 1, it looks like a, what do you think about this? There is a bleed, grade 1 bleed or no bleed? You can quickly type in the meeting chat. So suppose in one plane, if you see there is an echo dense at the ventricle, the anterior horn of the ventricle in coronal plane. And if you have, yes, Dr. Tanveer has said no bleed. Dr. Shalini has said there is bleed. So this is the confusion what you will have. This is the pitfall. So always remember in radiology that you should always take image in two planes. One in coronal section, in another one in sagittal section, or in anterior fontanelle one view and in posterior. So here in coronal section it looks like a bleed, but when you look at the sagittal section, there is no bleed. You can see the dip of cardothalamic groove. So this is the pitfall which you need to remember when you start diagnosing. There is no big deal about diagnosing a bleed. If there is massive bleed, will come to. When you have a subtle bleed, when you have to counsel the parents. So grade 1, can anybody tell me grade 1 bleed, it is difficult to counsel, or grade 3 bleed difficult to counsel? Grade 1 difficult or grade 3 difficult? Because in grade 1, when you put a probe, you see some amount of bleed. If the bleed, acute bleed, the ongoing bleed is happening, and if it is massive bleed, yes, grade 1, Dr. Tanveer has said grade 1 bleed difficult, because if there is acute amount of bleed, I was talking about the venous angle and the terminal vein. So you see, you put a probe, and then you see a bleed, and you see it grade it as grade 1, and you start counting. always make sure that when you are counseling the parents, when you see a bleed, grade 1 bleed, please tell the parent that prognosis is hard because you do not know how it will progress. If there is an acute massive bleed, it can compress on the terminal vein and it can cause venous infarction on the periventricular region wherever the veins drains. So it can lead to periventricular hemorrhagic infarction. That is the grade for what we are talking. So always grade 1 bleed, when you see, you have to serially follow up. If there is an acute ongoing bleed, it can damage and can cause periventricular hemorrhagic infarction. So you would have counseled grade 1 bleed, no problem, prognosis is good, and then you go. And then next, after 24 hours, you put a probe and see there is, hemorrhagic infarction which you would have started developing because of the blockage of terminal vein. That's why whenever in your practice, when you see grade 1 bleed or any bleed, you make sure that you don't tell that prognosis is good. You need to serially monitor and serially observe the progression of the bleed and the impact of the bleed. Now moving, I hope the grade 1 bleed is very clear how to diagnose and what are the pitfalls or where you can get misguided or misrouted, especially in counseling and especially in planning for the management. Now we'll move on to the next bleed, that is grade 2 IVH, where there is bulging of germinal matrix with rupture of germinal matrix and covering the blood covering the intraventricular system up to 10 to 50% of the ventricular area. So we will move on to the next slide. Yeah. So this is the grade 2 bleed. So in coronal section, you can see there is a bleed. 2 arrows have put, and in between 2 arrows, there is one more bleed in the third ventricle. When you take a coronal section at the foramen Monro, where you could see the third ventricle as well, along with the lateral ventricle, you can see clearly bleed is there on both sides, both right and left lateral ventricle, and even in the center between the 2 yellow arrow, there is an echo dense lesion. That is the third ventricle. So there is third ventricular bleed as well. So it has covered almost 50% of the ventricular system. So, and this is what we call it as grade 2 bleed, where it covers the 50% of the bleed. If bleed is acute, we will talk about the pitfall of grade 2 bleed in the coming slide. If the bleed is too much, bleed is there is a that this clot can go and gravitate and can be there in the posterior arm. So when you take a sagittal section or when you go with the posterior frontal view, you will see the clot present in the posterior arm. So if there is a clot present and if you are unable to make out in the caudothalamic groove, there is IVH and it is a grade 2 bleed. So this is the practical difficulties which you might come across. So in the next slide, I'm showing in coronal view the temporal, the posterior arm with a big thick arrow I've shown. The clot has got settled down in the posterior arm of the lateral or occipital arm, what we call. Next, if the bleed or the clot tries to take the shape of the ventricular system, lateral ventricular system, you can see here. So here also you will have confusion. Suppose if the blood, if bleeding has happened and it has covered the most part and you are not sure, please go with another plane. Here, even in very premature babies, the choroid plexus might look like a bleed, exactly like the way I've shown in the first slide. So you should always confirm with the coronal plane or from the posterior fontanelle you need to see. The second slide which I have put, you can clearly see there is an obliteration of caudothalamic groove, plus there is a clot which is present in the posterior arm. So there is IVH and it is a grade 2 IVH. So this is the practical difficulties which you will come across. Now coming to the pitfalls, what are the difficulties you come across? Suppose if there is a bleed and it's just the shape of the lateral arm of the ventricle in the parasagittal section. You can see an echo dense lesion, obliteration of the caudothalamic. You can see in the arrow I've mentioned, 3 arrows I've mentioned, there is an hyperdense lesion, echo-dense, followed by echolucency, again echo-dense. You can see like a track. So usually the clot, if a choroid surface is smooth, you can see that echolucency between, you can differentiate clot and choroid plexus with the echolucency. If the surface of the choroid plexus is rough, then you will have practical difficulty in actually identifying the bleed. So this is another pitfall what you might come across when you are doing in grade 2 bleed. Now I'm going to put the third slide. There will be three images, A, B. I want the audience to say whether the bleed is there in A or not. First we'll go with A. You can answer looking at the thing. So you can see there are two arrows which has been put. One in the caudothalamic groove in a parasagittal section or a paramedian section, and I've put another mark in the occipital horn of the lateral ventricle. So A, there is a bleed. The participants can type and answer. If there is a bleed, any doubt? Then yes, there is a bleed. So next B, picture B. You can directly see that clot has settled down in the occipital horn, but you cannot clearly make out the caudothalamic groove. So I want everybody, yes, correct. I want everybody to answer slide C, whether there is a bleed or there is no bleed. Yes. See, the picture C, there is no bleed because you can see caudothalamic groove, a dipping of caudothalamic groove, and there is no clot in the posterior horn. Always confirm with another plane, go with coronal section, go with posterior fontanel view, because most of the time we just do anterior fontanel view and we leave it there. That should never be done. Try to do in all the windows. You will get valuable information, and your doubts will get cleared, especially in terms of management and in terms of counseling the parents. Now, yeah. So the next slide which I have put is always make sure that you see bleed in always more than 2 planes. Never forget to look at 2 planes. Yes, I have put one more slide. Two picture, one from the posterior fontanelle. This is the anterior fontanelle. I have taken the parasagittal. The second image is the posterior fontanelle. I have taken an image. So you can see in anterior fontanelle, if you take paramedian or parasagittal section, the occipital horn will be down. If you see the second image, that is taken sagittal section taken through posterior fontanelle. So you can see the posterior horn of the lateral ventricle is erected. It's going up. So this is how you differentiate the image. So you can see on. Can anybody tell me if there is a bleed or no bleed? Looking at the image. First, I have marked the thing in the first image with an yellow thick arrow. You see something in the posterior horn. Same baby, you have taken posterior fontanelle, and then you are trying to see. You don't see anything in the posterior horn. Yes, there is no bleed. So always make sure that you see in 2 planes. Now moving on to the, I hope grade 1, the practical difficulties what you come across. Grade 2, practical difficulties what you come across beyond identifying an echo-dense lesion or a bleed, how to differentiate the variations what you come across. Now on to the next type of bleed, that is a grade 3 IVH, that is presence of blood within the ventricle, and if it is more than 50% of the ventricular system, if it is covering with dilatation. So there is a coronal image and there is a sagittal image where you can see. Suppose if you see, just see the ventricle being big, and if you don't see any signs of bleeding, then it is not IVH. So always remember that ventricular dilatation alone is not adequate to call it as IVH. Especially when you are doing grade 2, if there is a grade 3, if there is a grade 3, if there is a minimal blood and there is a dilatation, again you get confused how to grade, whether it is grade 2 or grade 3. So in grade 3, if there is ventricular dilatation plus signs of bleed is there, then you call it as grade 3. So this is the next slide is sagittal view and a clot taking a shape of ventricle. A big bleed has happened, which we'll see in the next upcoming slide. There is a huge big bleed, plus there is ventricles being dilated, plus clot present in the posterior. Now we'll move on to the next slide. That is, you have to tell me whether it is grade 2 or grade 3. There are two images which will be upcoming. Yeah, this is the image. In first image, you see a lateral arm is dilated, and you see occipital arm of the ventricle is also dilated. On the second image, in the sagittal section, you see there is a signs of bleed, caudothalamic groove. There is a bump which is seen, and there is ventricular dilatation. Now you tell me, grade first image is grade 2 or grade 3, and you can see grade 2 or grade 3. First image is grade 3. But there are no signs of bleed. But if you look into the sagittal section with the same baby, you see there is a caudothalamic groove, there is a bump. Yes, it is grade 3. So always make sure that you try to see in 2 planes. But one more thing, if the clot is of, if the bleed is of longer time, inner lining of the lateral ventricle becomes thick. Especially even in meningitis, you might have thick lining without any signs of bleed. So in that case, you don't call it without signs of bleed, you don't call it as intraventricular hemorrhage. So please remember. So this is what we were discussing. The next slide is about the pitfalls which I have mentioned. That if there is signs of bleed and ventricular dilatation, you call it as intraventricular hemorrhage. If there are no signs with only pure ventricular dilatation, we don't read it as intraventricular hemorrhage. That is the next slide which will be coming up. Yeah, this is the one which we were discussing, the pitfalls. So moving on to the next slide, that is presence of periventricular hemorrhagic infarction. Suppose if there is an acute bleed which has happened, grade 1 bleed which we were discussing, you should be careful. It is the grade 4 bleed which is their classification. But Olpe made it that this particular 4th grade is removed and made as a separate entity because the damage or injury what you see is because of the compression of the terminal vein by the acute bleed, and that leading to hemorrhagic venous infarction. So that is what is called as PVH. Next, I'll be putting the role of Doppler in color Doppler in germinal matrix hemorrhage. So this is the upcoming, this is the slide which you can see here. Before hemorrhage, germinal matrix hemorrhage, you can nicely see, like in Deepavali, you have that the flower pot where you can see the colors. Like you can see on both either side of the hemisphere. When you put a color Doppler, you can clearly see all the branches of the chordate veins, the thalamus straight veins. You have your all the arteries. It beautifully looks similar on both the slides. Whenever there is a bleed, you can see on the second image with GMH we have written. You can see that GMH where I have written in white color. On that side, especially on the left side of the image, you can see the color Doppler has disappeared. So this is how it looks like in color Doppler whenever there is bleed. So not just doing a 2D image, put a color and see whether there is infarction. You will easily come to know by either by dilatation of terminal vein, you will be able to see, you will be able to pick up in Doppler. Then you will be able to see whenever there is infarction, the color goes off in that particular area wherever there is infarction or wherever their hemorrhage has happened. So this is the role of color Doppler in germinal matrix hemorrhage. Next one is a very interesting slide which I've put. So it is the color Doppler which I've put, which is an upcoming slide. In this, you will see Yeah, the next slide, which will be coming up, will be the thing where you can, see how the color plus the Doppler simultaneously when you do, how it appears, especially in case of bleeding. I think it's not moving. Anyway, we'll move on to the next slide. That is the summary. We'll take up that during the discussion time. The color slide. So I hope the grade 1, grade 2, and grade 3 lead is very clear. This is a summary of grade 1 in coronal section. The second column is grade 2, and third column is grade 3, how it looks in coronal and sagittal section. You can clearly see in first slide, first column marked with the triangle, white triangle. You can see there is a small bleed. In grade 2, you see the ventricles being covered with dilatation. In grade 3, you see a big clot and the more dilatation of the ventricles. Similarly, on the sagittal section, you can see the difference between grade 1, grade 2, and grade 3. This is how exactly it looks like, and you can easily differentiate from grade 1 to grade 2 and grade 3 bleed. So neuropathological consequence of IVH has already been covered by Dr. Shivu. So I'm not going to talk about consequence. We'll move on to the next type of bleed. So till now, we have discussed and we have treated germinal matrix bleed. So I request the participants to kindly mute. Can you mute? Can you mute all? Yeah. So this is a choroid plexus bleed. So till now we discussed about germinal matrix hemorrhage and how it is graded, grade 1, 2, 3, and what is post-hemorrhagic venous infarction, how it looks in coronal section, in sagittal section, role of posterior fontanelle views. Now we'll move on to the choroid plexus bleed. In choroid plexus bleed, any bleed in ultrasound, it appears like a whitish or echo-dense lesion. So in choroid plexus bleed, usually when you take a measurement from anterior to posterior, it's around 12 mm in length, hyperechogenic than usual, and it is nodular. You have seen the germinal matrix bleed is smooth. In plexus bleed, it will be in the choroid region, that is on the posterior part, where I have put the arrow, and it will be nodular. So this is what it looks like. Now we'll move on to the periventricular hemorrhagic infarction, because that is a separate entity altogether. So incidence of this is around 15 to 20%. Whenever there is an acute massive bleed, it can cause compression of the terminal vein or the venous drainage around the lateral ventricular system. That can lead to infarction. So wherever there is infarction or the venous drainage is blocked, you see changes or damages in the brain around the periventricular region. It could range from parietal to frontal to occipital or to temporal. The damage can be seen all across. So periventricular hemorrhagic necrosis is a venous infarction. It is not from end. It is 50% of it, or extending from parietal to occipital. As I said, it can range from, depending on which part of the venous drainage is blocked, you see the hemorrhagic infarction in that particular area. So that's why it is more localized, and it can be asymmetric. If one part of the brain, in the left hemisphere, if there is a massive bleed, and if there is a block, but if you don't see bleed, it is not symmetrical. So why I'm telling this particular thing is, we need to differentiate between PVL versus PVHI. So this helps you in understanding why why it is unilateral, why it is asymmetry, why it can range from parietal to occipital. So the next slide, which I'm talking about, the pathophysiology of PVHI, post venous hemorrhagic infarction, where we were talking, I had shown the venous drainage system around the lateral ventricle. You can see on the first image, there are few veins. There is one in center, you see a U-shaped vein. On the top, we have written as internal cerebral. That is a vein which drains into great cerebral vein. Both right and left forms a great cerebral vein, also called as vein of Galen. That goes into straight sinus, then into the sigmoid sinus. So you can see the medullary veins, anterior terminal veins or caudate veins, terminal veins, which I was talking about, the venous angle, and base vein of Rosenthal. That is on the upper surface of the third ventricle. So whenever there is an infarction or block in this venous drainage system, you can see I have put in oval shape around the lateral ventricle. All these parts can have injury or damage or infarction. So unfortunately, I had a wonderful video. Probably I'll try to show it at the end of the session. There are two videos which I need to show. This is the video which I'm unable to play in another computer which I am projecting, but in discussion I'll show you. There is a small bleed, oval-shaped bleed next to below the lateral ventricle, you can see. So if that bleed extends, it compresses the blue color thing, that is your terminal vein, and can cause infarction in that particular. I'll show you the video in the once the discussion is done. So now moving on to the next one, which I was talking about, which I've already mentioned you, pathophysiology, how the blockage of terminal vein leading to post-hemorrhagic infarction which happens. So I've put few images, how it looks like in the first image you can see here, which we can discuss during the discussion time. I can put a separate image and we can discuss about color Doppler, role of color Doppler in post-hemorrhagic infarction. So next slide, I'm going to put how the evolution of how the post-venous hemorrhagic infarction evolves from a simple grade 1 bleed to post-venous hemorrhagic infarction, how it happens. So this is the slide. You can see there is a small bleed which has happened on the left, below the left side of the hemisphere. You can see in a circular thing. And then in the second slide, I have marked a thin blue line. So where the bleed has increased and it is trying to put pressure on the terminal vein. In the third slide, you see because of the blockage of terminal vein, you see an impact in the area where it supplies, the terminal vein supplies the hemorrhagic infarction. This is how the grade 1 bleed which we were talking, that when you are counseling a parent, you should be very careful. You see a grade 1 bleed and you come out and never say that grade 1 bleed, nothing will happen. This you tell guarded because of this particular reason. It can evolve, it can block terminal vein, and it can cause blockage of venous drainage and venous hemorrhagic infarction. This is how the pathophysiology of the hemorrhagic infarction happens, or grade 4, what we call with the previous one. I'm going to put the slide of the brain, how it looks like, how it evolves and how it looks like. You have three section of brain which I have put, and in the behind one, the bigger one, you see an IVH and germinal matrix bleed is written. Then you have a second one on the left side of your screen. If you see there, I've mentioned distended terminal vein above GMH. I hope you are able to see that. In a third slide, since it is distended, it has caused impact on the area where it drains, the venous drainage. And you can see IVH and venous infarct. So this is how in histopathology real the brain looks like when there is an acute massive bleed. It causes distension of the terminal bleed and then infarction of the terminal bleed. This is how it looks like in histopathology, or when you take a cut section of the actual brain. So inside the brain, this is how it looks like. Now my next slide is, it is very important for you to differentiate, because periventricular leukomalacia also you have echo dense lesion. Post-hemorrhagic infarction also you have echo dense lesion. So you need to differentiate between the two. So as I said, post venous hemorrhagic infarction is venous in origin because it is caused due to the blockage of terminal vein, whereas PVL is because of the changes what you see in the arterial system. It is unilateral. If one side there is a massive bleed, it can cause a fan-shaped hemorrhagic infarction, whereas PVL you see around the periventricular region. So it is bilateral, patchy, irregular, and it is like it covers. So it is symmetrical PVL, whereas hemorrhagic infarction, venous hemorrhagic infarction is asymmetric. Unilateral, where it has bilateral. Rapidly progressive, you see on day 1 there is a grade 1 bleed, and after a few hours you come and see the bleed has increased, and by 24 hours you see there is a hemorrhagic infarction. Whereas PVL is a slow changes. At times for 7 days you might have some periventricular flare you will see, and then it takes some time for periventricular leukomalacia. That's why we have in the upcoming slide I will be telling you the difference between the physiological periventricular flare versus pathological periventricular flare. So it progresses slowly. So it forms a single cyst, whereas periventricular leukomalacia forms the multiple small cysts. This is a venous infarct. Generally, it communicates with the ventricular system, whereas periventricular leukomalacia don't communicate with the ventricular system. So I'm going to put a slide of the next slide with color Doppler and images of the periventricular hemorrhagic infarction. You can see there limited terminal vein area of infarction, extensive terminal vein area of infarction. You can see the entire brain has become echodense in the second picture on your left side of the screen, where I have written extensive anterior terminal vein area infarction above the caudate nucleus. You can see there, and in color Doppler you can see there is no color in a place where there is infarction which has happened. On an image C also you can see the difference. There is a dilatation, and you can see on your right side of the image how the color has disappeared. So acute appearance, how it happens, and in end stage how it happens. This is the slide. So there is a cyst which can communicate with the ventricular system. Usually it will be unilateral cyst. So here in the next slide I have put a color Doppler and try to see the terminal vein, and you can clearly see the terminal vein, and you have post-hemorrhagic venous infarction in the second image, where you can see a color Doppler on your left thing, on your right, where I have written PVHI. You can see there is no color of terminal vein is blocked. That's why color Doppler is not picked up the terminal vein. So use of color is also important, especially, and plus Doppler. I've got a wonderful study which unfortunately I could not put it. I'll put it in discussion time. How the color Doppler helps in differentiating the grading of bleed as well. So the next slide is an overall view of post-hemorrhagic evolution of post-hemorrhagic venous infarction. I'll give a few seconds. You can just memorize what I've told you. This is the slide, and I've put in the center the veins, how the angulates, and what are the areas which can where you see the infarction. Now, summary of IVH. So doing at optimal time and frequency of or the serial scans is very important. Never ever diagnose and try to declare or come to conclusion or give a judgment with one scan saying that this baby has scan and that's it. So, and don't try to label it or paste it as good prognosis or bad prognosis. You need to serially monitor the bleed, how it behaves, how it progresses. So it is important. You need to follow the screening protocol. There are many pitfalls in the diagnosis of intraventricular hemorrhage. So once you know the pathophysiology which I have mentioned and how to differentiate grade 1 versus physiological or grade 2 pitfalls and grade 3 pitfalls, if you are aware of this, it's easy for you to come to a conclusion. So next, so the bleeding has happened now. You have graded the bleed. Now you are trying to look at the complications of bleeding. That is ventricles being enlarged. So ventricular measurements of brain is very important. Ventricular measurements, we have Leibniz ventricular index or Davies scoring system, and then we have certain charts and things. So this is the Leibniz ventricular index system. You can see there, we are trying to measure. I put an yellow line from the center, spark cerebri, to the maximum diameter of the lateral ventricle. So this is the distance what we measure. So, and then we plot it in the next slide. I'll show you. We'll plot it in a graph. If it is more than 97 centile, that's an indication for you that this baby's ventricle system is getting dilated and it can going into hydrocephalus. Suppose if the dilatation is more than 4 mm of 97 centile, then so this is the chart which you can see, which is a coming slide. If it crosses 97 centile, you should be alert that ventricles are being dilated and it can lead to hydrocephalus. So that's why if the ventricle is dilated 4 mm above the 97 centile, there is 60% possibility of baby having shunt. So this is the chart I'm talking about. Fifth centile, you have 3 lines on your left chart, and there is a box-like chart that is ventricular width centile chart. So there you have 2 lines. One, you have 97 centile, which is dotted line, plus the solid line on the right side of your chart inside the box 1B where I have written. There is a dotted line that is 4 mm above the 97 centile. Suppose if it crosses that, there is 60% possibility that baby might go into shunt-dependent ventricular dilatation. On your left side, you have 3 lines. Center, you have one solid line, whereas 5th, 50th, and 97 centile. So if it crosses 97 centile, even 1 mm above the 97 centile, it's an indication that you should alert and you should serially follow, and you should tell that if you intervene once it crosses above the 97 centile early, you can reduce from 60% of shunt-dependent lesion to hardly 15 to 16% reduction in shunt requirement might be there if you diagnose early. So that is the beauty of the ultrasound, especially the measurements when you are doing it. You get to anticipate the problem. Next is the Davis reference code. Here, it's a combination of 3 measurements what they take: anterior horn width, thalamo-occipital, and third ventricular width. So here also, if anterior horn width is more than 1 mm over the 97 centile, 1, and in all the 3, you will be able to get an idea about dilatation of the ventriculars. Anterior horn width, I've told you how to take from falx cerebri. You need to, that is the Levens scoring. Anterior horn width, what you do is you take the maximum diameter of the lateral horn of the ventricle. That is the next slide which is coming up. How to take anterior horn width, how to measure thalamo-occipital distance, and how to measure the third ventricle. So when you are measuring anterior horn width, try to take the coronal image at the level of foramen Monro, and you take the maximum measurement of the anterior horn of the lateral ventricle. AHW is anterior horn width. That is how you take. So ventricular index, you measure from the falx cerebri to the cerebral hemisphere width. HW is nothing but cerebral hemisphere width. So if the ventricle VI, that is ventricular index, if it is more than 50% of the cerebral hemisphere width, then it is also a marker or a measurement, one of the measurements which is used in actually assessing or getting an idea about the ventricular dilatation. So next upcoming is the chart which I have put about the anterior horn width. There is a chart which is available. For less than 4 days there is one chart, and more than 4 days there is another chart. This is a chart where you need to plot and get an idea about the where it exactly falls, whether it falls on the 97 centile or not. The middle line what you have seen is the 97. Thalamo-occipital distance. Thalamo-occipital distance is the distance you take measure from the posterior aspect. First, you need to take a image on the sagittal, parasagittal section. That is, you keep the marker towards the eyes, the face, place it vertically, and try to tilt it, moving away from your sagittal, central sagittal. You take a sagittal and you tilt it towards the lateral side, you get the parasagittal section. So this is what the parasagittal section. And then you need to measure, put in a yellow line, the posterior aspect of the thalamus to the posterior aspect of the inner surface of the lateral ventricle posterior horn. This is how you need to take the thalamo-occipital distance. And there is a chart available for this as well. For less than 4 days, there is one chart, and more than 4 days, there is another chart. Whatever you get measurement, you put it there, you get an idea about whether it has crossed 97 centile or not. So that you can score it in Davis scoring, where you take anterior arm width, thalamooccipital distance, and your third ventricular diameter. Next is third ventricular diameter. When you place a probe in the mastoid area, you get to see third ventricles in better way, or in a temporal window also you can get it. So then you measure the maximum width of the third ventricle. This is the image where you can measure the third ventricular width. Fourth ventricle measurements is also taken. I've put a probe, you can see there, and I've put next slide, how to measure the fourth ventricular measurement. You place a probe on the mastoid window, and then you measure the maximum width of the fourth ventricle, which will be upcoming in the slide. So you need to remember that Levin scoring, you need to remember the Davis scoring, and you need to know how to take measurements. And then you can plot it, you will get an idea of the ventricular dilatation. Next thing is put next slide about the hydrocephalus ex vacuum and evolving hydrocephalus. So you need to have a basic idea. I'm not going to go into detail of this. Just one slide, which is enough for you. You can see that if it is in the next thing, you can see that ventricle still maintains the concavity on the lower surface, the anterior horn of the lateral ventricle. And on the second slide, you can see that that concavity is gone and it has become concave, and the arrow mark which I have shown, yellow color arrow mark. So just have an idea about this. Next, I have put a slide on how to measure the subcortical spaces, especially if you have the hockey stick probe. You can beautifully measure the subcortical width as well. So that is the next slide. These are the other measurements or views which you need to take. So next slide, I'm going to put on the mean, standard deviation, and the normal range of each and every thing. You don't have to remember it. You have to keep it posted. Take a printout, keep it posted in your NICU, and whenever you take a measurement, you take a printout, take all the measurements, write it down, and try to plot it, and then you can compare it with your chart. This is the chart which I've put. Anterior arm width, normal range is 0 to 2.9 mm. Thalamooccipital distance 8.7 to 24.7. Third ventricle 0 to 2.6. Fourth ventricle 3.3 to 7.4 mm. And fourth ventricle length 2.6 to 6.9. So you just take a printout of this particular chart and stick it in your NICU, and whenever you do measurement, you need to look at all these things. We have synocortical, cranocortical width, interhemispheric fissure width, and third ventricular width. This is also slide I have put. You don't have to mug up. Just take a printout, and whenever you want to know the normal range, just take a printout and try to refer it. So moving on to the hydrocephalus follow, the assessment of intracranial dynamics. You will come across now the next slide, which you will be seeing is the other measurements. Just for the completion's sake, I've put that particular thing. The upcoming one is very interesting. We are coming to almost end of the session. We have the next upcoming thing is the hydrocephalus follow, where the assessment of intracranial dynamics by transcranial Doppler in a perioperative period in pediatric hydrocephalus is used. And with the Doppler, you can actually see whether the baby is going to develop the hydrocephalus or not. I think the slide is not moving. Yeah, it's moving now. Yeah. So this is how you take a measurement of anterior cerebral artery. This particular thing with next 2 to 3 slides is a very nice slide and with a very good information. You are taking a mid-sagittal view for anterior cerebral artery position and for the Doppler. And then you place Doppler and you try to calculate the resistive index with the color Doppler. And this is how you take it. You take a proper, angulate it proper, try to get a nice view of your anterior cerebral artery, which is encircling around the anterior aspect of your lateral ventricle. So you can see schematic diagram on the left side, and you can see the colored Doppler which I have put on the right side. So this is how you take the color Doppler of anterior cerebral artery. Next slide, which I'm going to show with the Doppler measurement, you see a systolic peak and a diastolic peak, and then we calculate the resistive index. Whenever systole peaks and diastole reduces, your resistive index goes up. So the normal resistive index, when you calculate, because most of the machines will have automatic calculation. So that is how you do. This is the thing how you take the color Doppler and the measurement of resistive index. So next slide I've put on the normal range of resistive index. It's between 0.6 to 0.8. Automatically your machine calculates if you have the resistive index software within your machine. Yeah, so we will see that this is the image which I was talking about, anterior fontanelle, how to take the resistive index, place a probe, take a good angulated sagittal section, and then place the Doppler at the angulation of the anterior cerebral artery. Now, role of Doppler in a premature one baby to predict hydrocephalus before and after the drainage procedure. So the next slide is a very nice slide, where the first slide, there is 4 slides there, A, B, C, and D. I put color Doppler and the Doppler on the other side, the systolic and diastolic. First, we'll go with first slide. So here you have a intraventricular hemorrhage has happened, and then you suspect the ventricular dilatation or hydrocephalus. Now you are doing a Doppler. So you place a machine, you place a probe, and then you get this Doppler image. That is the first image, A. So when you place a Doppler, subsequent to that, you can see there is a systolic peak and a diastolic peak. And then you measure the resistive index. You can see in the first image, the resistive index is 0.921. That is more than the normal one. At this stage, if suppose if radiologists are coming, say, once a week, or your pediatric surgeon is coming once a week, you need to tell them that to plan for the shunt procedure, you need to have a prediction. So this particular slide which I put will help you in actually guessing whether the kid is going to develop, baby is going to develop hydrocephalus or not, or baby would require shunt or not. So in the first slide, where the resistive index which you calculated is 0.921, and in the subsequent slide, where what we have done is we have tried to put a mild pressure through the anterior fontanelle. Just imagine, take a probe or take your hand, put it in your sagittal view on your head, and try to put pressure on the anterior fontanelle. So when you put a mild pressure, you are trying to make the ventricle, dilated ventricle, press the anterior cerebral artery and try to get the resistive index of that. So the second image which I have put here, the B, where we have put a mild pressure in the sagittal, when you're taking a sagittal view, the marker facing towards the face, you put a mild pressure, and then you take a Doppler, you see resistive index, because you are trying to mimic the blockage of anterior cerebral artery by putting the pressure. So you can see resistive index has gone to 1.238, and even diastole, if you see, there is a reversal. So this baby, when you have done without putting a pressure, it was resistive index was 0.921. So your pediatric surgeon would say that we'll wait for a week and then we'll see. If you put a mild pressure, you are anticipating and you are getting an idea about the requirement of shunt. So when in the second image, that the B image, you have put mild pressure and you see that the diastolic has become reversal, and resistive index from 0.9, it has gone up to 1.238. So you have predicted. So in the third image, what we have done is we have tried to drain some amount of cerebrospinal fluid. So we have drained the fluid, and then we have done the Doppler again. There you can see the resistive index has come down from 0.9, it has come down to 0.27. So now what we have done is we have put again in the fourth image, D image, we have put a mild pressure again. So you don't see, you see resistive index, again it has gone up to 0.814. This is how you anticipate even before a full-blown hydrocephalus is developed. You can actually help pediatric surgeon and involve them early, and you get an idea about this baby are going to develop the hydrocephalus or not. So this is how you actually get an idea or predict with color Doppler the requirement of the shunt. Now moving on to the next topic, I hope I've made it very clear. Moving on to the next topic, that is periventricular leukomalacia. So there are gradings. The way I remember is the periventricular echo density around persisting beyond 7 days, grade 1. Grade 2, you start seeing a small amount of cyst around the periventricular region. Grade 3, the involvement of this cyst moves up. Grade 4, from periventricular area to the subcortical area, you see extensive cyst. That is your grade 4. So first, you see only echo dense lesion. You see a periventricular flare persisting beyond 7 days. You start seeing few loculated bilateral cysts on frontoparietal region. Then grade 3, that cyst increases. Grade 4 is nothing but from subcortical area to the periventricular area, you see extensive cystic lesion. So these are the few slides which I have put. The upcoming slide, how exactly the echo dense periventricular leukomalacia looks like. See, when you look at the next slide, which is coming here, it looks like a bleed. But as I said, you need to differentiate between a bleed versus periventricular leukomalacia. See, both the sides, it is bilateral, small, symmetric, and it is not homogeneous. It's it's inhomogeneous. This is your grade 1. Suppose if you see this in a, say you have a 25-weeker or 26-weeker, you take a coronal section at the level of foramen Monroe, and then you see this periventricular flare. If it persists beyond 7 days, only then you call it as grade 1 bleed. By then, if it disappears, then it is physiological, because the glial cells of premature brain will be filled with more cytoplasm. That's why it will appear more whitish. So you might get deceived as a periventricular or a grade 1 periventricular leukomalacia. So when you are counseling, always you should tell there is some changes we have noticed in the initial bleed. If that changes persist beyond 7 days, then we call it as grade 1 bleed. Till 1 week, you cannot, unless there is a massive, prenatally or antenatally, the changes have evolved and you are seeing a cyst already evolved at the time of birth, then it is a different thing. But when you are doing a scan, when you are counseling, please make sure that you take time and you do a serial scan. Only then you tell after 7 days about the situation of the baby. You do one scan, you see, you feel grade 1 or grade 2 and direct straight away, don't tell them. After 1 week, it might disappear. Moving on to the second grade, where you start seeing some localized cysts around the periventricular region. You can see on both the slides, small cyst in between that echo dense lesion. This is your grade 2. Grade 3, that cyst will extend. Grade 4, you see cyst extending from subcortical, the entire range from the cortex, subcortical region, to the ventricle with ventricular dilatation. Posterior horn, occipital horn of the ventricles have gone up. The lateral horn ventricles have increased in diameter, and you can see the complete involvement of the brain. This is your grade 4. Key messages, as I said, flare, periventricular flare, localized cyst, extensive cyst, and subcortical leukomalacia. If you remember this much in this way, it is more than enough. So grading is done for you to get an idea about the involvement of the brain injury. So if you remember like this, flare, localized cyst, extensive cyst, and subcortical leukomalacia, that is enough for you to. Thank you. So I request Dinekar sir to moderate the session. Meanwhile, I'll try to put 2 important slides, very, very important slides which we missed. I'll try to project it in my another laptop. Over to you, sir.
Hello.
Hello, sir. Yes, sir.
Excellent talk, Dr. Prashanth. And beautiful talk. Really, I was impressed when I came to Karniokan. You are the one you have enlightened about Vajpayee Arogyasri and what is that, Ayushman Bharat. Thank you.
Yes. Yes, sir. Thank you, sir.
Very, very happy. There are almost, I think, so 9 hours, 9 or 9 or. First question to Dr. Prashanth.
Yes, sir.
First question, sorry.
Yes, sir. Yes, sir. Please tell me, sir.
Okay, no, we'll ask him because there are nine questions are there for him. Okay. Is PVL is decided in utero or it happens after the birth?
Sir, PVL is because of the hypoxic changes. What?
Yes, sir.
Sir, PVL happens because of the variation in the cerebral pressure of hypoxic changes. The changes what we notice in the brain cells. So it can happen prenatally also. It can happen post delivery as well, depending on how the circulation of the brain has been compromised, either inside the uterus or outside the uterus. It can happen, sir.
It can happen.
Yes, sir.
Inside
yes,
the
sir.
uterus also.
Yes,
So
sir.
it can happen because of outside the insult also. Is it correct, Shivanagoudru?
Yes, sir. Yes, sir. Because it is the hypoxic injury which is causing to develop. So it might happen in utero also, perinatally also, postnatally also.
Okay. So suppose now one baby has delivered. Now it is 28 weeker. I can see PVL grade 1.
Okay.
Sorry, grade 0. It is persisted after even up to 2 weeks. So, but after the delivery, there was no insult at all. So do you think this baby will develop PVL in the later life? Now it is 2 weeks baby.
Sir, we have to follow up this baby. So in a scan we have to do at 36 weeks or a term. So because it is multiple hit hypothesis is there, so we have to follow up the baby. We have to follow up ultrasound and we have to see whether this baby will further develop or not.
Yes, sir. So we have to follow up the PVL.
Yes, sir.
Okay, sir, exactly what is the cause for PVL? Because you told in your, what is it? In your talk, it can develop in utero or later also it can develop. If it is so, the mother never had any problem in utero. I mean, fetus never had any problem, I think. So what he is asking. What then? What is the reason?
So the anatomical factor is there, sir. Anatomical factor, there will be end vessels are there around this periventricular area. If there is changes in the cerebral blood flow also, it will affect, sir. Even it is because the blood flow changes, cerebral blood flow changes also will affect. So there are multiple reasons. Even at birth, if the baby was fine also, after that, whatever the changes in the cerebral blood flow, whether there was hypocarbia, so we have to see all the things. So there are chances if the baby is normal at birth, doesn't suggest that the baby will not develop PVL. There are chances are there. So we have to do an follow-up ultrasound scan in these babies.
Yes. So the question follows once again. I am relating because there are nine questions people have asked. There is, I am relating one more question because he is on the line who has asked the question. Sir, you told because of hypotension it can develop. PDA will be there in utero. Later PDA will get closed.
Yes, sir.
If PDA persists also, it will happen, you told, because of hypotension. Even IVH develop also, it can happen. So without that, then PVL can happen for all the babies.
Sir, for
so
all
what is your explanation?
Yeah, all the preterm babies who are born less than 32 weeks, the ultrasound is compulsory, sir. We have to follow up those babies because there might be changes when the babies were there in the NICU. There might be small, even the physiological changes will also affect the cerebral blood flow. So even the baby has intubated tracheal suctioning. So even in physical stimulation, the small changes also will affect the cerebral blood flow. So we have to follow up these babies. We can't tell nothing has happened and this baby will not go for PVL.
Yeah. what is the relation between magnesium sulfate and IVH?
So magnesium sulfate and IVH, there is no relation, sir. Presently, there is no evidence that magnesium sulfate will reduce the chances of IVH, but there is an evidence that it has neuroprotection. It will reduce the neurological stability will be there. But present, as far as present evidence is not there for IVH.
So antenatal steroids will prevent IVH.
Yes, sir.
Is it helpful in PVL also?
Yeah, it is helpful in PVL also because antenatal steroids will provide cardiovascular stability. So that will prevent the babies going for hypotension and the need of inotropes. So it will help in reduction of PVL.
Yeah. So number one, can you tell now better in periphery we can manage? Can you tell how better in periphery? Periphery means probably rural area. He is asking. We can manage post hemorrhagic hydrocephalus.
So post hemorrhagic hydrocephalus, we need the help of an radiologist, and we need the help of pediatric surgeon for post hemorrhagic hydrocephalus. If their ventricles are dilating, they have to follow up, and if required, then later if the ventricular dilatation is happening, they have to go for stenting. We have to take help. If it is not there in your place, we have to call. At least they can visit once a week and all, so that we can handle. Without the help of that, it is difficult.
Yeah. So what is that? One more question. How acetazolamide will help in post hemorrhagic ventricular dilatation? Exact dosing and regime.
So, presently, we are not used, sir. I have no idea about the dose and the regime in hydrocephalus and all.
Yeah, because there is no regime, exact regime not there, but whatever we are using for acetazolamide, same thing we are using like furosemide, acetazolamide, same thing we are using, but exact dose and regime, nobody knows. So one more thing, PVL, is any genetic factor is there, or any ethnic people are more prone?
As far as there is no race or ethnic genetics are involved, presently only the anatomical factors and the intravascular factors as given. Genetic predisposition, it is not given. So I don't know any genetic predisposition association is there.
Yes. So how to differentiate between PVL and post hemorrhagic venous infection other than ultrasound? Theoretical, how to differentiate?
Theoretical, it is little difficult, sir. So PVL and periventricular hemorrhagic infarction, it is difficult to differentiate.
One is arterial watershed area, another is
venous area.
So okay, that is the one. But one is one hypotension, but everything can happen. Ultrasound wise, I think so. Same thing somebody has asked. Dr. Prashanth, the same question somebody, he has continued. Ultrasound wise, how can I diagnose PVHI and PVL?
Yeah, as I said, PVHI, as the name suggests, it's a venous infarction. So there is a blockage of, I just played a video of how it can, the terminal vein can get blocked and can cause infarction. I'm sure all the participants have seen. So that is how the pathogenesis wise, it's unilateral, whereas PVL is an hypoxic ischemic insult because of the arterial. So one is venous, another one is arterial. One is unilateral, it is bilateral. One is asymmetrical, large, and it can communicate with the ventricular system. That is your PVHI, venous hemorrhagic infarction. Whereas arterial, that is PVL, won't communicate most of the time, and it is diffuse. Whereas this is inhomogeneous, one is homogeneous. So these are the few, and even when you put a color Doppler also, you'll be able to get the idea about the terminal vein getting dilated, or the part of the terminal vein you won't see the color over there. So this is how you differentiate ultrasound wise. So ultrasound wise, looking at the image, looking at the Doppler, looking at the size or site, we decide.
Yeah.
Yes, sir.
How frequently are we supposed to do the cranial ultrasound in a baby based on gestational age of the baby, and how to follow up?
See, based on the gestational age, yes, sir, yes, sir. See, the simple way what we tell is you try to do within 24 hours, 3 days and 7 days. Suppose if you want to go with scans based on the gestation, then less than 28 weeks, less than 1 kg, or 28 to 31 weeks, or less than 1.5 kg with life support. Try to do it before 6 hours, one scan, day 3 to 1 week, second scan, and by 1 month, third scan. And at the time of when baby reaches term gestation, or when you are at the time of discharge, you can get one scan done. This is based on 28 weeks, less than 1 kg, or up to 32 weeks, less than 1.5 kg on life support. If suppose if it is 28 to 32 weeks with birth weight of 1 to 1.5 kg without life support, we advise before 3 days to 1 week, one scan, by 1 month, second scan, and when they reach term gestation or before discharge, do the third scan. Suppose if they are 32 to 34 weeks gestation with risk factor, or if the head circumference is less than third centile, or ventricular index, or the post surfactant, fetal distress, acidosis, if Apgar score is not good, then we advise before at day 5 to 1 week, and in between, as and when required, you can do it. This is based on the gestation wise. Simple to remember is less than 24, 3 days, 7 days, you have to do one scan.
Yes.
For all the
Thank you.
Ways. Yes.
Yeah, it is enough. So I think so. There is one more question for Dr. Patel Nimge. Is there any role of intranasal administration of breast milk in treatment of IVH?
No roles. As far as I know, there is no role and evidence, sir, presently. As if you know, you can add on, sir. Presently, I don't know.
I don't know. That is that somebody has asked the question, just I passed on it to you. I don't know. Regarding this, I don't know. What is the Prashant?
Yes, sir.
Hydrocephalus and RI. Can you explain once again, sir?
Yes, sir. See, I put a slide on estimation of predicting the hydrocephalus in a baby with the color doctor. So normal resistive index is 0.6.
Can you show that slide?
I'll try to show, sir. There is a technical problem. I'll try again to show.
In the meantime, Patel, what is the prognosis of baby with the shunt for hydrocephalus?
So it depends upon multiple factors, like the shunt complications, one thing. Second thing, what the grade of intraventricular hemorrhage was there. So if it is a grade 3 and periventricular hemorrhagic infection, the prognosis is bad because 75% they will develop neurological deficits. So that is one part. And second part, if you put a shunt complications are there are chances of infection. So shunt blockage. So these are all the things which will add on worsening of the prognosis.
Yeah. So that yes, Prashant. Yes, that is the one.
Yes, sir. Yes.
So after this question, only you have to answer, Prashant. This is the one.
Yes, sir. Yes, sir. So here we have 4 images: A, B, C, and D. In first image, you put a probe
can you
and you see
enlarge
that resistive. It's getting enlarged, sir. It will take around 7 to 8 seconds. It will enlarge. It will enlarge. It does enlarge.
Yes.
So first image, there are 4 images which is marked as A, B, C, and D. So in first image A, you have taken a probe place it over the baby's head, and you have tried to calculate the resistive index. So here you can see in the first image, there is systole and diastole both are present, and then we have calculated the green color, two lines are there. Systole, S is written, on the down it is diastole, that is D is written. So resistive index of this particular color Doppler is 0.921. So it is more than the normal. Normally it should be 0.6 to 0.8. 0.921, more than 0.8 you get it in your thing, but it is not more than 1, it is more than 8, 0.8. Then what we do is, we try to put a mild pressure from the probe over the anterior fontanelle of the baby, mild pressure. Why we do that? We are trying to mimic the ventricles, trying to compress the anterior cerebral artery. So when you put a mild pressure, if there is an impending hydrocephalus which might require stent is expected, when you put a mild pressure and then you take a Doppler, you see diastole reversal has happened. In the bottom, if you see here, in the bottom, the diastole has come down. So whenever diastole decreases and systole peaks, your resistive index goes up. So in the second picture, that is B, you see because of mild pressure and we have tried to mimic the impending hydrocephalus requiring stent, the resistive index from 0.921, it has gone up to 1.238. So you get an idea. So you don't have to wait. If somebody, for a radiologist or pediatric surgeon weekly once, you put a Doppler and you tell him, no, this baby requires stent because I have done this. Then what you do is you try to drain some amount of CSF fluid and then again do the Doppler. So third image is after drainage of CSF, I put this Doppler. I've done this Doppler. You can see their resistive index has dropped down from 1.238. It has dropped down to 0.727. Again, you put a mild pressure and get a Doppler one more time. So here you can see that resistive index from 0.727, it has gone up to 0.814. So this baby, if you would have left it without drainage, baby would have had damage of the brain injury because of the blockage of anterior cerebral artery. So this is how you utilize the color Doppler to suspect the impending requirement of stent. Yes, sir.
Yeah. So it's very clear. Before it goes for the 97th percentile, we can predict and we can place the VP shunt. That's what you want to tell. Okay.
Yes, sir, yes.
Dr. Prashanth, how to differentiate between acute bleeding from old bleeding in the ultrasound?
Yeah, see, as I said, whenever bleed happens in the brain, in ultrasound it appears as a whitish or echo dense appearance will be there. So in acute bleeding, you get to see that echo dense lesion or hyperlucent appearance of the ultrasound image. As the blood starts, becoming a clot and clot starts retracting, from periphery to center, this hyperlucency or echo dense starts shrinking and it becomes echolucence rather than echo dense. It becomes echolucent. The old bleed will shrunk in size, and you see a layer of hyperlucence, and then from periphery to center, you start seeing the clot retracting. And you start noticing the echolucence below that. So this is how you differentiate. And serial monitoring of the X-ray ultrasound will get an idea about the progression of the bleed and the appearance of the bleed. So would you like to add anything apart from this, sir?
No. That is enough. So yes, new bleeding will appear hyperechogenic. Old bleeding usually dissolves and it will be in between it will be like a debris floating. Later it will get resolved. Before resolving, it will sit on the neighbor surface, nearing choroid plexus and this thing. It will look like an hyperechogenic. Later it will come down. That's it. Sir. So all the questions are over. No, regarding the breast milk, intranasal breast milk for premature infants with severe intraventricular hemorrhage and observation. It is from Titz Keller, European Journal of Pediatrics. Okay, it is in 2019 for nasal application of neurotrophins and mesenchymal stem cells successfully delivery to the brain, and therapeutic effect are known from experimental data in animals. Human breast milk contains neurotrophins and stem cells, but gauge tube feeding in preterm infants bypasses the nasopharynx. This is the first exploration and additional nasal breast milk and neuromorphological outcome after severe neonatal brain injury. Okay, this is the one. 1 second. Conclusion. The hypothesis is generated that early intranasal application of breast milk could have a beneficial effect on neurodevelopment in preterm infants. Controlled investigations are needed. So what is this in clinical covariates were comparable in both the groups. With nasal breast milk, a trend to lower incidence of severe porencephalic defects. 21% it has reduced compared to non-breast milk. Non-breast milk is 58%. If you put the intranasal breast milk, because of the stem cell, it has decreased to 21%. The incidence was lower for progressive ventricular dilatation. 71% it has reduced. In control group, it was not put. It was 91% gone to the ventricular dilatation. And surgery for post-hemorrhagic hydrocephalus, 50% it is reduced compared to the 67%. So there is so many articles he has sent. Dr. Abhijit, thank you very much, my dear friend. Even we were not knowing. That is the reason webinars are making us open the eyes. Thank you, my dear friend. So speakers, thank you very much. Great, great, great. Shivanagoudrau. Sorry, Patel.
Thank you, sir. Sir, thank you so much.
No, dear. You are very nice person. More than that, very humble. More than any that, you are a very knowledgeable person, helpful. You were telling me how you saved the babies, but you are having the zeal to improve better way. Thank you very much. So Dr. Prashanth, as usual, excellent, beautiful. Now in the last you played the video also. So how grade 1 hemorrhage will go for a PVHI, means periventricular hemorrhagic infarction. But I request everybody, whoever on the line, please learn ultrasound brain and do venous study. It is little more better, because you can do diagnose whether IVH will develop or not for some babies with additional risk factors like intracerebral vein study. So what our Prashanth Gowda has explained, it is very beautiful. Thank you, dear Prashanth. Excellent topic. You have collected all the things material. Very good, dear friend.
Thank you.
Thank you on behalf of NNF. Prashantha?
Yes, sir. Yes, sir.
Can I ask a question?
And all. Yes, sir. Please ask the question, sir.
Sir, what percentage of cases with intraventricular hemorrhage progress progress to progressive hydrocephalus?
Patel Re, name the question.
Sir, sir, I didn't get the question.
Means if there is a IVH is developed, if it is a grade 2, grade 3, what is the percentage it will develop post-hemorrhagic hydrocephalus?
Progressive hydrocephalus.
Sir, we have to follow up only, ultrasound only. We have to follow up with that only. We will come to know whether these babies will go for progressive hydrocephalus or not.
Sir, once intraventricular hemorrhage is diagnosed, when we should refer these patients, when we need to refer these patients to a pediatric surgeon? And in what
sir,
condition?
first we have to follow up these babies on ultrasound. If there is a progressive ventricular dilatation only, then we can call the pediatric surgeon and ask their opinion, sir.
So once intraventricular hemorrhage is diagnosed, what are the prognostic factors are there? How we should judge the prognosis of the patient?
So, and follow up only, we'll come to know what we can explain at discharge if it is there. So what may be the chances of neurological implication, what percentage this baby might get. Grade 1 it is 15% neurologically impairment. In a grade 2 and grade 3, according to studies, we can predict and we can tell them. So you have to come for follow up and we have to see how the baby is going to be. At discharge we can see and then we have to follow up these babies.
So the ultrasonography, when it should be repeated again and again, sir?
Dr. Prashanth.
Prashanth.
Yes, sir. Sorry, sir.
When
I could not hear
ultrasound should
properly.
be repeated.
If you get a bleed.
Yes, sir.
Yeah.
In IVH, when you should repeat ultrasound?
Yeah. See, as I said, within 24 hours, first scan to be done. Suppose if you are seeing a grade 1 bleed, try to repeat it in next few hours, maybe 4 to 6 hours again, and try to follow it up. So minimum scan required is less than 24 hours, at least one scan to be done before day 3, second scan, before 7 days, third scan. These are the minimum required. In between, based on the pathological, the progression of the problem, bleed, you can do as and when required. Must is less than 24 hours, less than 3 days, before 7 days, to see the progression of the IVH. But in between, if you feel that it is increasing in size, bleed, or if hemorrhagic infarct is developing, then you can do as frequently as possible. There is nothing like that. You should not do only 3 times.
Do you require MRI?
Yes, sir. Yes, sir. Obviously, by 1 month at least, if diffusion perfusion study is not there, because ultrasound is able to give some amount of idea about the ongoing damage if it is appearing in the brain. MRI is must sir, to get an idea about the overall idea about the brain injury. By around at least by 1 month, you should be able to do it, sir.
Thank you very much, sir.
Neonatologist can report as point of care ultrasound perspective. There is no legal implication on that. Basically, PCPNDT is for somebody had asked about neonatologist reporting as a point of care ultrasound. It reports, but for your diagnosis and management and follow-up, you can tell your findings. That is not the exact reporting. It is that will help you in management. That can be done. No problem with that.
Prakash,
yes,
sonometro Maximax.
Sir?
कल भर चले थे अब कल भर सुबह शाम दिला दी कल खुद नहीं.
Okay, sir. I think we will. Yes, sir.
Excellent session. Thank you, NNFK and Dr. Prashanth.
Yes,
really nice topic. Patil Rain, very nice talk, really. So PVL, you have
thank
told.
You so much, sir.
PVHI, you told. So thank you very much, my dear.
Sir, thank you for the opportunity, sir.
Thank you, one and everyone who had attended.
And one more thing, please, my dear friends, wear the mask. Take care. COVID everywhere. Now I don't know whether it will transmit even in everywhere it is there. Please take care, dear friends. Please take care.
Yeah. All right. Take care. We'll see you tomorrow again. Bye. Have a good Saturday. Bye.
Bye.
Thank you. You're able to listen to your voice there. Thank you.